Conventional transrectal ultrasound-guided detection of prostate cancer is limited by underdetection of clinically significant cancers and overdetection of indolent tumors.
Okay, Michael, we're just about done.
Despite recent advances in prostate imaging using multiparametric MRI, the majority of biopsies still make use only of ultrasound. To fill this gap, at UCLA we've instituted an MR ultrasound fusion prostate biopsy program to help make use of the information from MRI to improve biopsy detection of cancer.
Prior to biopsy, the MR data must be contoured. I find that contouring the prostate first is beneficial, as that way I have a sense of where the boundaries of the prostate lie. Choose the border of the prostate on each of the 3 T2 weighted images: axial, sagittal, and coronal. I outline the prostate usually on the axial images first. When I've completed outlining the prostate, I choose Finish Segmentation, and the computer will generate a 3-dimensional volume of the prostate. I will then return to the layout and choose a 2x2 format with the axial T2 weighted images in the upper left, the sagittal reformat of the T2 weighted images in the upper right, the perfusion map, in this case K-trans, in the lower left, and the ADC map of diffusion weighted imaging in the lower right. In this way, I have multiparametric imaging. I can now identify targets by outlining them using the Region of Interest tool. I outline the target on each image and then choose Finish ROI. I will now assign a level of suspicion to each of the targets based on quantitative and semi-quantitative analysis of the diffusion imaging, perfusion imaging, and qualitative analysis of the T2 weighted imaging. So I will choose the suspicion level as very high. It now changes the color of this target to red. Finally, to confirm that I have an adequate target, here we can see in 3 dimensions the contour of the prostate and the target in the anterior aspect. When this is complete, I return to the case viewer and notify my clinical colleagues that they can now transfer the data by burning a CD, which is then input into the Artemis fusion biopsy device.
The procedure we are performing involves MRI ultrasound fusion to perform targeted prostate biopsy. The patient is positioned in the left lateral decubitus position, just as for a conventional prostate biopsy. First, a regional prostatic block is performed by infiltrating 1% plain xylocaine at the base of the prostate dorsolaterally, tracking the neurovascular bundles. Next, the geometric volume of the prostate is calculated, 41.2 cc's for this prostate. The next step in this procedure is to bring the cradle of the Artemis device up into the ultrasound position. To bring the ultrasound probe into the cradle, we try to keep it as horizontal as possible, and a scan of the prostate is then performed by rotating the probe manually across approximately 200 degrees posterior surface of the prostate. Okay, that looks nice. During segmentation of the prostate is outlined in a transverse and longitudinal plane. This allows us to isolate the prostate, remove it from surrounding structures, and work with it as a 3D reconstruction on the computer screen. During global alignment, the MRI image of the prostate is fused with the real-time ultrasound image of the prostate.
Fine. Okay.
And a MR ultrasound fusion is performed. Following fusion of the MRI image with real-time ultrasound, any targets that have been delineated by the radiologist appear on the 3D reconstructed model, and we are able to aim our biopsy needle at these targets then, as well as perform systematic biopsies throughout the prostate according to the map furnished by the device. The prostate can move either by its movement within the body, or the whole body of the patient can move, distorting the image fusion. Therefore, built into this device is motion compensation software, which allows the tracking mechanism to return to the original site of the prostate. Our custom is to take one biopsy every 3 millimeters of the longitudinal axis, the longest axis of the lesion noted on MRI. If the patient has had a prior Artemis guided biopsy and has positive lesion identified during that biopsy, that site of that biopsy is tracked and can be reconstructed and superimposed on the new 3D model of the prostate, and we can then target the same area to see if the positive area before contains more or less tumor as identified the first time around. We have learned that we can come within just a few millimeters in terms of retracking our biopsy site. Biopsy site tracking is one of the main advantages of this device. With this device, the software allows the radiologist to color code the suspicion, the level of suspicion of these lesions. Red is the most suspicious of the colored lesions. One special circumstance where this targeted biopsy method is of great value is in men who've had prior biopsies of the prostate because of elevated PSAs, but their biopsies are negative.
Our preliminary study showed fusion of MRI and real-time ultrasound to be accurate in patients to within approximately 3 millimeters. In the first 106 men with prior negative biopsies and persistently elevated PSA, targeted biopsies diagnosed nearly twice as many men with significant cancers, but 5 times fewer men with insignificant cancers.
At the end of each biopsy session, we offer the patient reassurance that this form of biopsy is more reliable in terms of detecting prostate cancer, and that if his biopsies are negative, that he will have a reassurance that not otherwise possible, and that if there is anything there, that we have a greater likelihood of finding it than we would with conventional blind biopsies.